What I will be presenting will base on our finding as part of the pancreatic cancer sequencing project of the International Cancer Genome Consortium, and a couple of little stories from there. First one being using the whole genome sequencing to define the mutational landscape of pancreatic cancer and also define a DNA damage repair defective molecular phenotype that those patients preferentially respond to DNA damaging agents. So that's the first story. And second story is something that we've submitted recently that's under revision on the integrated analysis of the 450 cancer genomes that we've sequenced. And the major finding of that is we find 4 major sort of molecular subtypes of pancreatic cancer based on the different gene transcription program, as well as their prognosis, as well as also where we think we might be able to use these gene programs and representing each subtype to better help us elucidate and to find out different novel mechanisms that we could target. Even just rationalize the drugs that we have on the market, number one, or two, yes, potentially new drugs that can be used to target particular pathway or particular sort of overactivity in a subtype of the cancer. For the DNA damage repair DNA damage repair defective phenotype, it has been sort of shown, which we know for a while already in breast and ovarian cancer, that they preferentially respond to DNA damaging agents. For pancreatic cancer, there were some signals in previous clinical trials, but this was probably the first time that we were able to explain it genomically. And this sort of particular signature is also now being inferred, not just in breast, ovarian, pancreatic is now also been shown in gastric cancer as well, which was just recently published in Nature Communication, not by us, but by the Sanger group. First of all, pancreatic cancer, it is quite heterogeneous genomically. It probably is dauntingly heterogeneous that when you first look at it, you think, okay, well, where are we going to start? How are we going to tackle this? But I think using different ways of analyzing these genomes, we should be able to group the similarities together and then actually tackle them from that sort of fashion, rather than going straight down to thinking that there's no way of breaking sort of this disease. So that's probably number one conclusion. Number two, that I will also present is probably some of our recent experience in personalised medicine in pancreatic cancer, which was a feasibility study that we conducted in Australia before we moved to Glasgow, to show people what real life personalized therapy in pancreatic cancer looks like. It's not simple. There's a lot of obstacles, but we've learned a lot from it, which I will share with the audience. And also we'll bring out something called Precision Panc. It's a sort of research and treatment platform that we want to set up here in the UK as a platform that we could bring forward to bring the community together to see how we could tackle this daunting disease, really. Yeah. We've learned that these patients are usually, because the setting of the trial, the inclusion criteria of the trial is that the patient has to be in a metastatic setting, meaning that they can deteriorate very fast. So a rapid turnaround of molecular information is probably the most crucial thing. And we found that we were able to return the information, 75% of the patient with the information within sort of 4 weeks. But even then, we still see a good proportion of patients who later on become not eligible for the trial because of they either passed away in that sort of period of time while they're waiting for the result to come back, or their performance status actually deteriorates so much that they no longer are fit enough to receive any more chemotherapy. So rapid turnaround time and a good communication between the molecular multidisciplinary team and the treating oncologist are the keys that we've learned.